We don't have any financial disclosures. We haven't found any between our last presentation and this one. But as we just said, we are recording it. So thanks for continuing in the session and providing your consent for that recording.
But today we're going to talk about pneumonia, and the way we're going to kind of break it apart is talking about evaluation and treatment for mild, moderate, and severe pneumonia. And we'll talk about kind of what that context and framework means. We're also going to talk about the algorithm that we use at UC Davis for empyema and how that management has shifted over time. And then finally, we're going to talk about the relevant UC Davis guidelines. And I'm going to let you go take over, Leah, and explain the QR code.
So the QR code in the corner is the one that takes you to the UC Davis pediatric guideline. And then that will include our pneumonia guidelines as well as our empyema guidelines, and we'll put it up a couple of times. And then there will be a different QR code later for some of the imaging that we're using. So just to be aware that there are a couple of different QR codes in this presentation. So as we kind of break these patients up into mild, moderate, and severe, I feel like mild is the bucket that's the easiest to separate out, because I think we can kind of categorize these as children who are well enough to be able to go home. So these are our outpatients. And so thinking about who that group is, they're usually kids that are statting well on room air, right? So they don't need supplemental oxygen. They're not having significant respiratory distress or work of breathing. They're tolerating oral fluids at home, preferably foods as well, but at least fluids, and will be able to tolerate oral medications. And then overall, they're pretty well appearing. So non-toxic, don't look like they have sort of overwhelming systemic infection and would need hospitalization for that reason. And as we sort of think about that group, it's a group that we see in the emergency department frequently, and probably this is also a group that shows up in clinic potentially even more often than we see in the emergency department. And luckily, these are patients who we can diagnose clinically. So we don't need to get blood work, we don't need to get labs or cultures routinely in this group. Everywhere you look, it reminds us that pneumonia is a clinical diagnosis and that imaging is not necessary. I will say in my setting, it is pretty ubiquitous that we actually get chest x-rays in these kids. If pneumonia is on our differential, certainly high on our differential, then we'll get the chest x-ray. I think some of that is the luxury of having radiology immediately available. And if you have to send a patient farther away to get that, it's different. I think if you're not sure of the diagnosis, the x-ray can definitely be helpful. Or if you're sort of trying to decide severity, it's also one more piece that can play into that. So I'd say extremely low threshold to get a chest x-ray. And again, most of our kids that we see in the ED do get one. And then once we recognize them as having pneumonia, the first line treatment that we'll use, again, these are kids who are able to tolerate oral antibiotics, is high dose amoxicillin. So the 90 milligrams per kilogram per day. And then the evidence shows that there's better lung penetration if that is divided 3 times a day. Although Heather sort of did homework for us, checking in with our pediatric infectious disease team here to see, because we sort of realized that TID dosing versus BID dosing can be a lot more burdensome for our families. And so they sort of capitulated that although TID is sort of recognized as better, it's not necessarily going to make a huge practical difference. So I think that if you think, especially, it'll have an impact on a patient's ability to adhere to the medication regimen, that doing BID is a reasonable option. I think especially the more well-appearing the child is. And then we've really moved to a 5-day course, so that shortened course compared to sort of what I did in training of 10 days and then sort of marching it back to 7 days. And now we're pretty firmly at 5 days for treatment of routine outpatient pneumonias. There have been some good studies and some meta-analyses that have looked and have shown sort of similar success rates between those different durations, and significantly, at least statistically significantly, less adverse events in the kids who are getting the shorter courses compared to the longer courses. In our kids where we're suspecting atypical infection, so especially those in our older age group, we will also add in a 5-day course of azithromycin. And then the other group that we sort of think about is kids who have had a recent course of amoxicillin. I feel like we'll see a lot of kids who had a recent ear infection, maybe a URI that was associated with that, and then now have a pneumonia. And so in that group, or in a group that is unimmunized, then using high-dose amoxicillin clavulanate instead of plain amoxicillin is where we will start for them.
And what's the definition of high-dose augmentin?
So for the augmentin, we do the 90 milligrams per kilogram per day of the amoxicillin component. And when we do that, we have to make sure, and this has been an issue because we've had some errors actually associated with it, but making sure that we pick there's a proprietary formulation that's the Augmentin ES that changes the ratio of the clavulanate to the amoxicillin so that you can give that higher dose, that 90 milligrams per kilogram per day of the amoxicillin without giving them too much of the clavulanate.
Yeah, and for kids who end up getting too much of the clavulanic acid, a lot of times they're going to have a lot more GI distress. And I've had kids come back with pretty severe diarrhea and diaper rash who are getting the wrong formulation. So anywhere you look, if you're doing BID versus TID dosing, it'll indicate the correct concentration and formulation to use.
That's a project we've been actually working on again in EMR to sort of remind our clinicians of which dosing regimen for which indication, and then pointing them to the right formulation to go with that.
Next, we're going to talk about moderate pneumonia. So these are patients who get admitted inpatient ward level. This patient classification is kids who are hypoxic. They have increased respiratory distress. They may have signs of dehydration. I would say that's not unusual at all for this patient population. And then on their imaging, have either multifocal disease or a moderate to large pleural effusion. For these patients, we definitely are typically getting a chest x-ray and then focused labs. That usually includes a CBC and inflammatory markers. Cultures are not indicated, and the literature has been pretty consistent in showing that in the absence of having a kid who's super toxic or septic appearing, that they're not going to be helpful. In terms of treatment for these patients, we've made a big push to move from using ceftriaxone to ampicillin. So ampicillin, we typically use 50 mg per kg per dose, Q6, and then transition those kids when they're ready to oral amoxicillin. And then finally, same thing, if we're thinking about an atypical, we'll add azithromycin. And then also think about ceftriaxone in the unimmunized or patients with a penicillin allergy.
For the patients that a lot of these admissions are coming through the emergency department, and it's really interesting how hard it is to move away from ceftriaxone as for first line. I think it's what many of my colleagues and I have to sort of catch myself from reaching for it once we see a big pneumonia on X-ray, or even just a moderate pneumonia on X-ray in a kid who is sick enough that they have an IV. We'll frequently sort of reach for that, and so it's been sort of retraining ourselves that that ampicillin is adequate and that the kids do well, and I think it makes it easier to transition them to their oral regimen as well.
So when pediatric infectious disease subsequently gets involved, if they do, are they rather critical that cultures were never sent?
Not in my experience.
Okay.
I think part of what we're also seeing, and we didn't put some of this here, and I don't know how accessible it is in community settings, but we're getting more sophisticated testing in terms of, and we'll talk about that a little bit. So if they are needing more specific information, there's other things that we'll do for the kids who have really severe disease. But for the kids who have moderate disease, that is not something that has been an issue. So talking about severe pneumonia, so these patients typically are a PICU level patient. These patients are hypoxic despite just giving supplemental oxygen, so may need even more additional support, including potentially mechanical ventilation. As we were talking about, this is the patient who looks really ill, so toxic or looks like they have sepsis. For these patients, we would get cultures like we were just talking about, CBC, inflammatory markers. And then the other piece of this, and I'm going to have Leah comment on it too, is that in this population, we often are getting an ultrasound if we're concerned at all for an empyema. And so that'll help us to evaluate and see if that's part of the explanation of why this patient may look so ill.
I think some of that depends on what the chest X-ray looks like. So if it's pretty clear on the X-ray that it's that it is just a infiltrate and a consolidation of the lung, and that we're not concerned about fluid, then we don't necessarily get an ultrasound in all of these patients. But for the ones where we can't tell, and I feel like most often those are our lower lobe pneumonias where they're sort of sitting on the diaphragm and it's hard to tease out the difference. We have a very low threshold to get an ultrasound. And I'll usually do that with an ultrasound in radiology because I trust their skills more than mine. But some of my colleagues who have sort of grown up with their training in ultrasound are comfortable not only using ultrasound to evaluate for effusion, simple effusion, looking for loculations, as well as sort of assessing whether they're seeing signs of consolidation in the lung using ultrasound as well.
And then for this patient population, this is the group that we would put on ceftriaxone. We do still think about azithromycin in our older patients. And then if I would say our threshold's pretty low for adding vancomycin or Clinda. If they're super severe, we're going to think about vanc because that's bactericidal. If we just more want an adjunct, we'll think about clindamycin. And that patient population is patients who have influenza, have MRSA colonization. All of our patients get a MRSA swab when they're admitted, or patients who have a severe progressive pneumonia, so are rapidly deteriorating in terms of their respiratory status. And then, of course, give them respiratory support and manage any shock if that's present. So typically, I would say this population is often getting multiple boluses, and then variably, if needed, pressors as well.
This is a group you mentioned that we, all of our inpatients get swabbed for MRSA. I think it's something that we don't always prioritize in the emergency department. Sometimes it happens as they sort of go upstairs. And so if they've been boarding in the ED, that can be sort of prolonged. But in patients with pneumonia, this is a group that we try to get their swabs done early because we know that it potentially changes management. And then I think we didn't put it on the slides. I feel like it sort of is just understood in our times, but we're also, I would say most of these kids are also getting flu and COVID and then potentially RSV swabs when they're coming in initially with their respiratory symptoms. And so that recognizing the co-infection with flu happens pretty early because, again, we've had those respiratory swabs as just part of their initial workup. We've talked a couple of times about adding azithromycin, and I think that atypical pneumonias are one that we sort of know about academically, and sort of, at least I have a little bit of trouble knowing exactly how to kind of manage my practice around it. I think classically, we're talking about the mycoplasma pneumonia, the chlamydia pneumonia, and then in the older populations, we think about Legionella, but I'll say that doesn't happen often in our patient groups. And sort of classically, that's your school-age child with more indolent, longer lasting symptoms. And then their x-rays are sort of the bilateral hazy symmetric infiltrates. It's interesting as I look at some of the data that's been coming out, especially over the past year, as we're hearing about increased rates of mycoplasma, I feel like it's not as easy to differentiate as I would like it to be. The age group, it definitely still is more common in the older kids, but it looks like from the surveillance data that the CDC had, in 2024, we're also seeing an increase in the younger kids. So they report in that 2 to 4 year old age group that it's basically the rate has tripled and it's getting closer to where it is in that older age group. So something to think about in those younger kids. And then even chest x-ray findings, the presence of a consolidation, it seems like didn't statistically look different between the group with atypical pneumonia compared with our more typical organisms. So I think it's one that it's really good to think about, especially in kids who aren't improving on their usual course. We see a fair number of failed outpatient cases, and I tend to think that they need more of the typical coverage, and I need to kind of remind myself that that adding their atypical coverage might be what's making the difference. It's also something that I have thought about in kids who are presenting with new onset wheezing. So a kid without a history of asthma who is presenting with wheezing for the first time, especially in the setting of infectious symptoms like fever. I want to think about it in that group or in a group, the kids who have a history of asthma but have never been particularly severe and now have infectious symptoms and are needing admission or needing more escalation of their treatment. It's good to think about in that group. And then we have a lot of patients who come in with ill contacts, but if they tell us that, everyone has been coughing for a month or that other patients or other family members have been diagnosed with a pneumonia, I start to think about it in that group as well. Our viral respiratory panels that we perform at UC Davis that kind of test for our usual array of viruses will also test for chlamydia pneumonia and for mycoplasma pneumonia. So we sort of have the luxury that if we're suspecting it and we're not sure, we have that. We don't get it back in real time for the emergency department. It usually is sort of a 6 to 8 hour turnaround for those tests. But certainly for the inpatients, we can have that answer sooner rather than later and can tailor their antibiotics appropriately.
So the next thing that we wanted to touch on was how we treat our patients with empyema. I would say this is one of the things that have shifted quite a bit during the time that I've been practicing as a physician. where we used to put these kids on IV antibiotics. We were fairly quick to put in a chest tube, and then even quicker to potentially escalate those patients to get a VATS. And now we move towards taking it more stepwise and giving those patients a little bit more time to improve at each of those steps. We're also overall doing a lot less VATS, or I should say I'm not, but our pediatric surgeons are taking patients to the OR a lot less based on the evidence that's come out. So our first stop is evaluating the patient. Typically in any patient where we're this concerned, either because of the severity of their illness or the appearance, that we're going to get labs, x-ray, and ultrasound. Ultrasound, both looking for the size of the effusion, as well as trying to look and see if the patient has loculations or how organized that effusion is and whether it might be amenable to drainage or not. And then once we've done that evaluation, our next step is going to be thinking about how we're going to treat these patients. And so the blue boxes in the middle are from our pathway that you can access through the guideline that's on the right-hand side of the slide. But our empiric antibiotics for patients with an empyema are ceftriaxone. As you notice, it's higher dosing than our typical dosing. Instead of 50 mg per kg daily, it's 75. And then, as we mentioned on the previous slide, with the severe population, we're going to add the adjunct of either clindamycin or vancomycin. Our next step is thinking about further intervention. This is really only in the patient population that's been in the hospital for typically at least a couple of days and who's either worsening or not improving. The things that we're looking at in terms of improvement are looking at their fever curve to see if that has changed and improved. Even if it's not gone away, we at least want to see that their fevers are becoming less high and less frequent. And then ultimately, if they aren't improving, then we would consult with our pediatric surgeons or interventional radiology to place a chest tube and then put fibrolytics in the chest tube. I can't think of a patient that I've had at UC Davis who's gone for a VATS. Part of that's probably because those more severe patients are in the PICU. But I used to have a lot more patients that were floor status that were going for further intervention. Some of these kids, we do involve ID because they do need a lot longer term oral antibiotics as well in order to completely clear the infection given the severity.
And I think this is a group where if we recognize that they're ill at the beginning, Jack, going to your question, we will get cultures in this group because we recognize that they're going to need to be on antibiotics for longer or will potentially be sicker. Kids that are intubated, we're getting endotracheal tube sputum cultures.
Yep.
It's hard to get a reliable sputum culture in a kid who's not intubated. It's just hard to get them to sort of be able to provide that sample. But in this group, we can, as well as pleural cultures. So I think this is sort of that classic group that we want all of the microbiologic information, but less so now for our more straightforward, kind of that moderate pneumonia group.
Mm-hmm.
And then the only other thing I was going to mention is that sometimes for our really severe patients, we'll also get a Carius, which is an ID-driven test, but it's a blood test that helps identify what might be the source of the pneumonia. It looks for both bacterial and viral causes. That's typically only reserved for a really complicated patient where we want to make sure we're tailoring their antibiotic treatment appropriately. But that's something that is relatively new, and that's been helpful for that really ill patient.
Then we just wanted to spend a few minutes looking at some examples of chest radiographs from kids with pneumonia. The ones that we're showing here are borrowed from a Medscape article about imaging in pediatric pneumonia. The reference is at the bottom, and then the last slide actually has a QR code that'll take you to that article if you want to look at these images or others. The first X-ray that's up here is actually what they're calling a viral pneumonia, and I think that it's nice when the patients follow the textbooks and the images are really clear. I think we end up with a lot of sort of tweeners where we get the atelectasis versus infiltrate or small airway disease versus something on our x-rays. And so we end up having to sort of make the call. But there are times where it's more obvious than others. This example of small airway disease or viral pneumonia shows a lot of sort of markings right around the hilum. So you can see them kind of right next to the heart there. So perihilar thickening, they're calling that. And then around individual sort of medium-sized airways, there's that parabronchial cuffing, which is pretty characteristic. Again, this is sort of a symmetric pattern, more central than peripheral, that makes you think viral. I would say that I would wonder about atypical in this kid as well, and maybe we're getting a viral respiratory panel, so I would get that answer. And we can compare that to this x-ray, which shows a pretty classic right lower lobe pneumonia. So you can see that sort of hazy opacity that's sitting at the right base there, and compare it to the other side makes it easy to find. In this case, you can also sort of appreciate, if you look, that you can still see the outline of the diaphragm. So I think this is a case where you can be more comfortable that it's probably just a pneumonia and not an effusion or an empyema. But again, if there's concern, you can always get an ultrasound to try to differentiate those. And interesting, they actually provide this x-ray, and then the next one is the same patient 2 days later, who's now gone from that right lower lobe pneumonia. You can see it sort of extended up along that right heart border. So now it involves the right middle lobe. And whereas before we could see the diaphragm still outlined, here we've lost that contour, and you can see that opacity that's kind of climbing up on the lateral side of the chest, so consistent with an effusion in this patient. So again, you can tell that there is an effusion on the x-ray, but in terms of getting more information about it, if we were trying to determine, is this just an effusion versus is it an empyema, getting an ultrasound can be helpful for that. And then this x-ray, which is showing a left lower lobe pneumonia, is also my reminder to put a plug in. I try to, when I can, get PA and lateral x-rays. I feel like a lot of times we sort of click the box to get a portable x-ray because it's convenient, and honestly, sometimes it's a little bit faster in our department. But having the information that we can get from a lateral can be really helpful. This pneumonia you can actually see really well on the PA view as well as on the lateral, but certainly I feel like there's a number of infiltrates that are kind of sitting retrocardiac, so behind that cardiac silhouette, that can be hard to see unless we get the lateral film and sort of realize that space that's typically aerated on that inferior portion of the lung is not, and gives us a clue that there's a bacterial infiltrate that I think would be easy to miss on a PA film. And then this final x-ray, and again, there's that QR code if you want to look at the more of these images, is what's characterized as a round pneumonia. Kind of for obvious reasons, you can tell that the shape of it is pretty characteristic. It's a mainly pediatric phenomenon. So at least in the numbers that I saw, about 90% of round pneumonias are in kids under 12, with a higher proportion in kids under 5. It's not, treated any differently than our typical lobar pneumonias. The organisms are the same, but I think it's helpful to know about this one. You kind of get the sense, but in some of them, it is so round that it looks very much like a mass, like a pulmonary mass. And so I think, especially in people who are treating adults and used to seeing patients who have pulmonary masses more often than children do, just remembering that this is an infectious phenomenon, and that it's not something we have to worry about as being a mass. But again, you could get additional imaging if you needed to, but in a patient who's presenting with symptoms of pneumonia, around pneumonia is definitely a phenomenon that we see.
So some of the tips that we thought through while we were talking about these cases is community-acquired pneumonia can present as referred abdominal pain. I've had multiple kids where they come in and their primary presenting symptom is abdominal pain. We get a KUB, and then you might see a pneumonia in their lower lung fields that you capture with that. But there also are some indications that might be the case. And so the next bullet point is that for older kids who have mild tachypnea and are afebrile, that may also be a tip that they may have a pneumonia when they don't have kind of more florid or severe symptoms. Leah, do you want to go through the rest?
Yeah. And then we for kids who have a clear bronchiolitis picture or who have a positive viral testing for something like RSV, it is possible to get a superinfection with a bacterial process, but I'll say that that's quite rare compared to just having a primary viral process that stays viral. And so in these kids, that's part of the reason, and we talked about this with our bronchiolitis, that we don't get x-rays routinely in our kids where we have a high suspicion for bronchiolitis, because seeing lung findings can make it challenging to try to decide if it's bacterial or viral. And because it is more often viral, we end up kind of chasing our tail a little bit. So sort of trusting your clinical exam in those patients. The other thing that I think makes pneumonia challenging to talk about in general is that there's not really a gold standard for pneumonia because chest x-ray isn't needed for the diagnosis and, isn't 100% reliable. And then lung exam is also not reliable, particularly the younger you get. So our children who are unable to sort of take deep breaths on command, it can be hard to isolate those lung findings. And there's some studies by our emergency medicine colleagues who do a lot of pneumonia research who have shown that even among attending pediatric emergency medicine physicians who see a lot of children, there's not a lot of inter-rater reliability between their lung exams. So basically one person listens to them, they may hear one thing, and then the next person equally trained hears something different or doesn't hear anything at all. And so I just keep a low threshold for thinking about pneumonia in kids who are presenting with fever and respiratory symptoms, and considering chest x-ray or empiric treatment sort of appropriately for that group. And then the last group that we wanted to just bring up is kids who are febrile but don't clearly have a respiratory source. If they're getting a fever workup and we find a significant leukocytosis, so the literature that I'm familiar with is old, but it uses a white count cutoff of 20,000 or higher. The risk of occult pneumonia is in the sort of 10 to 15% in those at least in those older studies. And so considering a chest x-ray, because pneumonia may be your source of infection in that group, even if they're not having obvious respiratory symptoms, can be good to remember.
The thing I just want to put on people's radar is that we now have the expanded pneumococcal vaccines, and we're trying to target populations who are at risk. So our kids with sickle cell disease, our kids who are type 1 diabetics. We've done it actually in some patients who've had recurrent pneumonia. So just keeping in mind that that's another tool to try to prevent kids from developing a pneumonia. So finally, we've talked about our first line treatments: amoxicillin for mild pneumonia, AMP for moderate, and ceftriaxone for severe pneumonia. And then we've talked about the empyema is initially treated with antibiotics, and then a pigtail catheter and fibrinolytics if not improving, and that VATS is becoming much less frequent in terms of the intervention that these patients receive.